So let's talk a little bit about congenital ptosis surgery. I'll overlap a little bit with Dr. Iltuke. And really what it comes down to is, first and foremost, when do we operate? And then secondly, what do we do? So, a lot of it comes down to what is controversial in the treatment of congenital ptosis and what is not. And I'm going to limit this discussion, though, to non-syndromic ptosis or ptosis without aberrant innervation. So I'm not going to talk about Marcus Gunn. I'm not going to talk about BPES. I think bilateral severe ptosis with poor lever function, I think that's a relatively easy answer. I think we're going to treat this with frontalis suspension. In general, these patients usually are not amblyopic, especially if the ptosis is symmetrical and especially if they adopt a chin-up position. However, sometimes you'll operate early, but usually I'm going to let that be dictated by my pediatric ophthalmologist. So for severe ptosis, poor lever function, I'm going to do a frontalis suspension, and we'll talk a little bit about materials. So again, before and after frontalis suspension in this 1-year-old, and we can get a good result. I think it's really important to form the lid crease. So I go through a lot of trouble to form the lid crease in my patients with frontalis suspension. I think it's important for cosmesis, but also I think it prevents lash ptosis long term. So what you'll see in some of these patients long term who have undergone frontalis suspension is that they'll have almost a little entropion or lash ptosis after the surgery, or at least later on in life. And I think lid crease formation is important. So what do I do in order to create a lid crease? I think there's sort of 5 principles. I place the sling retroseptal when I do it. I always fixate the sling to the tarsus, so I do open a lid crease incision in almost all of my congenital ptosis cases. I don't ever take out any fat. It's always really tempting to take fat because sometimes it's in your way, but I don't take any fat. I don't take off any skin. I think you need that skin in order to fold down over the lid crease in order to create a lid crease. So lid crease isn't just a crease, but it's also a fold. And then I disinsert the levator aponeurosis from the anterior surface of the tarsus and actually incorporate that into the eyelid crease incision. And although you'd say, well, the levator is pretty weak, why would you do that? I think it's weak to lift the lid, but I think it's strong enough to pull a lid crease. So I will do that. With regards to sling materials, early on, lots of different foreign bodies to put into the eyelid, Supramid, silicone, Gore-Tex. You can use donor fascia. A lot of parents don't want you to use that. And then as Dr. Iltuke mentioned, the frontalis flap, which has had a lot of enthusiasm lately. However, if you put a foreign body in early, you need to prepare the patients to have another surgery at about the age of 4 to 5 years old. And usually I'm going to do autogenous fascia. I love autogenous fascia. I use a fascia stripper. It's a great material. It's the best material when I'm with regards to doing a sling. There are risks to foreign bodies, infection risk. However, they are somewhat easier to adjust. However, with fascia, there's very little, if any, infection risk, autogenous fascia. The leg incision, in general, heals very well. Knock on wood, I've never had a problem with a child with fascia stripping. They may limp into clinic a week later, but I haven't had any problems long term. However, it can be difficult to adjust these. So here we have a patient before and after her bilateral autogenous fascia sling. I think that's a good result with a good wood lid crease, pretty good height, could be a little higher. So we have a video here. Let's see if it works. So this is an example of autogenous fascia that's been placed earlier where you can actually identify it and adjust it. So I adjust my autogenous fascia, even though, in general, it's thought that it can be difficult to do. You can go through your lid crease incision, you can identify your autogenous fascia, you can actually take it off of the tarsus, shorten it, and put it back on. And so, even though it's hard to adjust autogenous fascia, you can do it. I also will often do a canthopexy at the time of my sling in some patients. And the reason that I do this is that what you'll see in some of these patients is that they have a little bit of retraction afterwards. And this, actually, I'll skip this video just because Dr. Sudar showed it yesterday. But I'd like a transblepharoplasty canthopexy. We can go to the next, so here we have a patient before and after this. And you can see on his lower lids, he has a little bit of retraction there. And so by tightening the canthus, I think that we get a little improvement in that lower lid retraction. And so I've been relatively liberal in doing transblepharoplasty or upper eyelid canthopexy in these patients. So, the big question is the amount of ptosis and levator function in congenital ptosis. And I think that one of the most difficult things in children is trying to figure out a levator function, and whether it's even worth trying to figure out a levator function in some of these kids. I think that can be incredibly difficult in younger children. I think what it has really come down to me is whether there's really such thing as a patient that has severe ptosis and fair or good levator function. I think by definition, if you see that patient with 3 millimeters or more of ptosis, they're going to have poor levator function. They're going to have poor levator health, I guess I should say, because really, is levator function an accurate measurement of levator health? The other thing that I look at is the eyelid crease, and the teaching is that if you have a relatively distinct eyelid crease, that you probably have a healthy levator function. I think that there is some validity to that. But in general, I believe that levator health should vary indirectly with the amount of ptosis. So if it doesn't, I really need to reassess that. So what I mean by that, if I see a patient with 1 or 2 millimeters of ptosis, they should have fair to good levator function or levator health. If I see a patient with severe ptosis, they're going to have poor levator health or function. So to me, I don't worry about it as much with regards to measuring those in those patients. So what do we do for moderate ptosis? I think for 2 to 3 millimeters of what I would call moderate ptosis, I think most of us would do a levator resection, especially if unilateral. I think that you're going to be able to find a muscle that's going to hold a suture, and you're going to be able to do that. So in general, you get relatively good results with a levator resection. Horner's syndrome, I think this is one thing in congenital ptosis that really responds well to a Mueller muscle conjunctival resection, as we had talked about earlier. So those patients with a Horner syndrome, congenital Horner syndrome, they do really well with a Mueller muscle conjunctival resection. That works well in them. However, there has been a push to do MMCR for other forms of congenital ptosis. I'm not as big of a fan for that. So if I see that kid with maybe 1 millimeter of ptosis, is not amblyogenic, really not causing any problems, more of a cosmetic issue, I'll give them a drop of phenylephrine to see if they respond. If they respond, then I'll probably do a pretty maximal MMCR on those patients. I think you have to do at least 9 millimeters to get 1 millimeter of elevation. But in general, this is congenital ptosis, and MMCRs work best in patients with good levator function. So in congenital ptosis, you're not going to have a completely normal, healthy levator muscle, so MMCRs aren't going to give you the same amount of elevation that you're going to see in involutional ptosis. One of the things that I've done more of lately, which is sort of blasphemy, is actually adding a tarsectomy in some of these patients. So I'll have those patients that have 2 millimeters of ptosis, pretty good levator health or function, fair response to phenylephrine. So what I mean by that is that the lid will respond to phenylephrine, but not completely resolve the ptosis. And I might add a 1 to 2 millimeter tarsectomy in these patients. I think there's risk in doing this. So what I mean by that is that if you do that surgery, you take responsibility for the patient. You don't send it to someone else for the reoperation because that tarsus may be unstable. Because there can be some difficulty in doing levator resections or frontalis slings on these unstable tarsus. So again, I think this would be a pretty good candidate for tarsectomy. And another kid, before and after his Mueller muscle with tarsectomy on the left, another one, she had an MMCR on the right and a tarsectomy with MMCR on the left, pretty good response. But I think one thing that I've noticed is that it lowers the lid crease a little bit. So when you look at these patients, their lid crease is a little bit lower. So the big question though is severe unilateral ptosis, what do you do? We could talk about this all day, lots of controversy. What drives my patient? Amblyopia, elevation of the brow. If they're not amblyopic, they'll usually raise their brow, they'll have a chin-up position. So those are good candidates for a unilateral sling in my mind. And I usually tell the patients they're gonna have to part-time patch until the age of 9 to want to use their brow. And so, kid on the right, great candidate for a sling. Kid on the left, not that great of a candidate. He's not lifting his brow on the right at all. Another kid, before and after, good candidate for a sling, lifting his brows. Really, this is what's gonna, and then this is a child before and after he had trauma. You can see he's lifting his brow, wanting to use his sling. If they're not amblyopic, they're not going to raise their brow, no chin-up position, hard to get them to use their sling, so I will go to a supramaximal levator resection on these patients. But I think you always have to be prepared to do a sling. And that decision sometimes changes intraoperatively. And what I mean by that is that if I have a patient with severe unilateral ptosis and I would take them to the operating room, I may plan to do a levator resection, but I tell the parents that if the levator really is atrophic, I'm going to do a sling. I will change my mind intraoperatively. So it's really going to depend upon the health of the muscle. And to me, this has led to many fewer undercorrections, but actually I've had a few overcorrections due to this. So my decision with regards is really dependent upon my subjective assessment of the muscle intraoperatively. And I think this can be difficult, especially in patients who have had previous slings with regards to what to do. Thank you very much.